Hey everybody, so we're gonna try and do some flipped lectures moving forward here, mainly because we've found that we haven't been getting a ton of scanning time with lectures and scanning during lunchtime. So hopefully with these flipped lectures we'll be able to get through some of the content a little bit more efficiently, leave a little bit of room for some question and answer time at the beginning, and then hopefully get a lot of scanning done, get more people through scanning. And between that and doing some free scanning sessions on Fridays, hopefully we'll get a little bit more benefit for everyone and get everyone feeling really confident with their scanning. So without further ado, we'll move into our topic for the week, which is pulmonary ultrasound. So a couple of objectives. So we're going to discuss some probe selection. We're going to discuss different scanning techniques for the various pathologies. We'll talk about patient positioning as well for different pathologies. Talk about some of the ultrasound modes that we can use for different lung etiologies, and then we'll discuss some of the etiologies more in depth. So some of the things that we can image, pleural effusion, pneumothorax are the two really big ones. The next three, pulmonary edema, pulmonary contusion, and pneumonia, they have a lot of really similar findings. And we'll talk a little bit about how to sort of pass those different etiologies out from one another. And we'll talk at the end of the session a little bit about pulmonary embolism. It's sort of a lower yield etiology to find with point of care ultrasound. It's more based on some ultrasound findings in combination with sort of clinical gestalt and some non-pulmonary ultrasound findings such as DVT or presence of DVT. So we'll talk a little bit about that as well. Okay, so we'll take a quick look at this schema for pulmonary ultrasound. So this schema was created along with the Blue Protocol, which was a study done in 2008 based on identifying lung etiology in critical care patients. So as you can see, it's sort of a clinical decision-making tool in terms of, you have this finding or that finding, and it sort of leads you down to the different lung etiologies. And so some of the findings, the B profile, A profile, is essentially the B lines and A lines that we'll talk about a little bit later on. And so this protocol, this paper, like I said, published in 2008, and actually found that they had a 90.5% diagnostic accuracy for those etiologies, which is pretty darn good. And some of the data since then has shown consistently high negative predictive values for pulmonary edema, pneumothorax, contusions, and effusions. Also has shown similarly high positive predicted values for those particular etiologies. Slightly lower values for pulmonary embolism, and we'll talk a little bit about that later. And the one caveat is most of these studies are done in a critical care setting. So you're dealing with sort of sicker patients to begin with. There's not a ton of clinical application for pulmonary ultrasound in a primary care setting. You still definitely do it. But like I said, most of this scanning is going to be done either in a critical care setting or in an emergency department setting where you need sort of a quicker answer on how to treat a patient that presents with dyspnea or those kind of complaints. So a little bit on probes using the butterfly right now. So we don't really have obviously we don't have a probe to choose from, but we do have different presets on the butterfly probe. So we have a pulmonary preset, which is what we'll be using primarily for this scanning session. Just adjust the presets a little bit so we have better definition where we need it. If you're using a traditional ultrasound machine, the sort of consensus is for pneumothorax, you're going to want to use the linear probe. Just higher frequency gives you better definition in a shallower depth, which is really what you're looking for because you're basically just trying to see the visceral parietal pleural interface for pneumothorax, which is fairly shallow. We're talking 3-4 centimeters maybe. For the other etiologies, you're looking primarily at the phased array or the curvilinear. Consensus is sort of more towards the phased array due to the smaller footprint and being able to fit that between the rib spaces a little bit more easily. You can still definitely use the phased array. It's just a little bit more challenging to get the image that you want between the rib spaces. So we'll talk a little bit about sort of imaging the lung, I guess, and really what we're doing when we're imaging the lung, because it is air-filled, is sort of imaging the absence of pathology, I guess. So if you remember from previous scanning sessions and lectures, air does not conduct ultrasound waves well. It sort of tends to scatter. So what happens is ultrasound beam comes down into the chest, hits the air-filled lung, and the ultrasound waves just scatter. And most of those waves are not going back to the probe, so there's no information coming back up to the probe. So it just, to the ultrasound machine, it seems like there's nothing there. And we'll talk a little bit about how different pathologies with, fluid and that kind of thing can then give you actual visualization of the lung parenchyma, which is kind of what we're looking for. So the absence of anything in the thoracic cavity is actually a good thing when we're doing pulmonary ultrasound. So some of the special signs that we'll discuss here in a couple of slides is the spine sign and mirror sign. And those ones are sort of fairly specific for pleural effusion. And in terms of scanning for lung pathology, we're really looking primarily at the anterior chest, anterior lateral, and lateral chest. There's a couple that we do have to scan posteriorly, and we'll talk about those when we get there. But their positioning is going to depend a little bit on what etiology you're actually scanning for. Okay, so pleural effusions. So as you can see by the stars, this is predominantly where you're going to be scanning, is the right upper quadrant and left upper quadrant views for the FAST examination. So you're really trying to get that interface between the peritoneum and the thoracic cavity right there, the diaphragm. You're also imaging a little bit at the costophrenic angle, which is basically where even small effusions are going to start to accumulate first. As we know, fluid is heavier and is typically dependent in the body, especially when the patient's laying supine. So the convention is to try and image these patients while supine if they can tolerate it. Some patients, if they have very large pleural effusions, they may not tolerate laying flat, so you may have to sort of compromise with that and image them with some head of bed elevation somewhere around 30 degrees or so is typically enough to keep those patients comfortable while you're scanning them. But that gives you sort of the best option or the best visualization of fluid at the bottom of the thoracic cavity. So there is a little bit of a push to try and quantify the size of pleural effusions. It can definitely be done, and there's a couple of specific calculations that you can do. One is the Remerand method, and the other is the Ballack method. Both of those they sort of involve a decent amount of math. They involve multiple measurements on your ultrasound. They involve a very steady hand and a combination of freezing and unfreezing images, so you can sort of get those measurements. And so I think for the scope of our sessions, I'd like to primarily focus our time on identifying pleural effusions that are big or not big. And when I say big, I mean large enough pleural effusions to have an effect on the patient's respiratory status. So I think if we can sort of parse out a large pleural effusion from a small pleural effusion, that's sort of as far as we need to go right now. There's definitely some videos if you're looking for a deeper dive on how to calculate either Rembrandt or Ballack, but it's not something that we're going to go super in depth on right here. The other thing you're going to want to do is try and qualify the effusion, so whether it's transudative or exudative. So transudative being, primarily just extraperitoneal or extracellular fluid, like proteins, water, that kind of thing, basically clear fluid. Versus exudative, which is, typically leaning more towards a higher solute content, things that are infected, that kind of thing, like empyema, those sorts of things. I did post a link there to a nice YouTube video that shows the plankton sign. It's kind of a weird name, but basically what it is within the pleural effusion that you're imaging, you're seeing sort of a fleculent material, so like a hyperechoic flex within the fluid, and that's sort of indicative of a more exudative process versus transudative. Not to say that a clear pleural effusion that you image that is just anechoic and black cannot be exudative as well. It's just one finding that is more specific for exudative, but like I said, anechoic, just black fluid, doesn't tell you transudative or exudative. Okay, so we're looking at mirror sign here. So if we look at the left-hand image, what you're seeing to the right of the screen, that's the liver. You're seeing diaphragm here where the white arrow is, that bright white sort of curved structure. And then to the left of the diaphragm, you're seeing sort of what looks a lot like liver on the other side of the diaphragm. So what's happening here is you have ultrasound beam coming down from the probe, hitting the curved surface of the diaphragm and bouncing back towards the liver. That wave's then hitting the tissue of the liver, coming back at the diaphragm and then going up to the probe. And the ultrasound machine isn't super smart, so basically what it thinks happened is that wave just traveled straight down in the original path, and so that's why it's sort of thinking that whatever was after the bounce off the diaphragm is just straight below it, and so that's giving you that artifact of the liver appearing below the or to the left of the diaphragm there. So this would be a positive mirror sign. Okay, so that's good. That is normal in appearance. On the right-hand side here, though, we see the liver on the right. We see the diaphragm, the bright white, where it's labeled there, and then we see a lack of mirroring of liver tissue on the left side of the diaphragm. Okay, and we see this fluid collection. Okay, so what's happening is ultrasound beam coming down and hitting fluid that conducts ultrasound waves well and just bounces back on its own, and you lose that artifact of the wave bouncing off the diaphragm, hitting the liver, and then seeing sort of liver tissue on the other side. This one's a little bit less specific than the spine sign that we'll talk about on the next slide, but as you can see on this right-hand image, you're also seeing what looks like positive spine sign as well. So spine sign. So we'll look here at the left-hand image first. So we've got liver here. You can see diaphragm here, this bright white line. And then this is a curtain sign, which is the lung moving down into your image as the patient breathes. Okay. And what you can see down here is you can see vertebrae below the liver. So these sort of the hyperechoic rim with the anechoic shadowing behind that. And so as the patient breathes, that spine disappears. So we can't see it. As the diaphragm moves down, these vertebrae disappear. Okay, so that's a negative spine sign. Okay. If we move over here to this image, again, we've got liver, diaphragm, vertebral bodies down here, so hyperechoic with the anechoic shadowing of the bone. And then as we move above the diaphragm, we can still see those vertebral bodies there, okay? And so basically what's going on here is we've got ultrasound beams coming down through the diaphragm, and as they get into the thoracic cavity, it's not encountering air-filled lung, okay? So there's something in here, typically fluid, that's allowing the ultrasound beam to penetrate through down to the spine and then bounce back up. So that's why we're still seeing the vertebral bodies here. So the positive spine sign, again, indicative of pleural effusion. And this one I feel like is a little bit more sort of intuitive than the mirror sign. And you can definitely still have, even with a pleural effusion, you can still have tissue or fluid on the left side of the diaphragm that looks really similar to the liver, but the spine sign is definitely a little bit easier to recognize. Okay, moving on to pneumothorax. So primarily you're going to start scanning up here, anterior chest, sort of at the apex of the chest, at the highest point, and you're going to want to scan several rib spaces. Okay, so sort of the convention is to start somewhere here, sort of second intercostal, something like that, mid-axillary line, or sorry, mid-clavicular line, sorry. And you're going to want to scan that rib space, move down several rib spaces, so you're getting a good idea of sort of the total lung tissue, and you're going to want to scan both sides. You're also going to want to scan laterally, sort of anterior axillary line, sort of right along here, to make sure that you're not missing some small pneumothoraces. And basically what you're looking for is the presence of lung sliding, which we'll cover on the next slide. So lung sliding is good, no sliding is bad. And if you do see a lack of lung sliding, you're going to want to keep imaging a little bit further to make sure that what you're seeing is actually pneumothorax. The presence of lung sliding alone is not specific for pneumothorax. It's indicative of pneumothorax, but there's a number of other conditions, including COPD, asthma, pleural effusions, apnea, main-stemmed endotracheal tube, patients that have had a pneumonectomy or lung transplant, and then blebs, which is basically a subpleural air collection that typically occurs in smokers, that kind of thing. Those can all also have an absence of lung sliding. So just sort of a caveat there, I guess. Okay, so we'll start here on the left. So looking at lung sliding, so what we've got here is probe up here. This is done with a linear probe. We've got some rib shadowing here. And then right here, this bright white line is what we're talking about. So that's the visceral parietal pleural interface, or the VPPI. And as you can see here, it's sort of got this movement along there. It kind of looks like, some people describe it as ants marching on a log. So this has present lung sliding. Okay, so as the lung moves along the parietal pleura, you get this sort of moving artifact. Okay, if we move over here to the right hand image, again, skin up here, chest wall, done with a linear probe. Got some rib shadowing here and here. And then we've got this bright white line. Again, that's the visceral parietal pleural interface. And we don't see any movement along there. Okay, so this would be the absence of lung sliding. Again, that's indicative of pneumothorax. And so in some patients, depending on body habitus and some other factors, it can be a little bit hard to see if there is lung sliding or not. And so what you can do is use M mode. So this is a couple of examples of using M mode to look for pneumothorax. So again, we've got skin up here, visceral parietal pleural interface along here. And so on the left here, this is a normal image, and this is called the seashore sign. So you've got what looks like sand down here, or the beach, and then you've got sort of the waves of the ocean out here. So we're looking right at the seashore, okay? And so these lines up here, these are indicative of no movement, okay? The sand down here, this artifact from the M mode, is from the movement of the lung, okay? If we move over here to the right-hand image, we can see we've still got that lack of movement from the tissue above the pleural interface. And then if we look below it, we still have those straight lines which are indicative of no movement. Okay, so you've got no movement above the interface, no movement below the interface, so complete lack of lung sliding there. Okay, so we'll move on to the lung point finding. And so the lung point is, as Matt said in his fast lecture, this is 100% specific for pneumothorax. So if you see the absence of lung sliding, this is why you need to continue to look in further rib spaces, because what you're looking for is the edge of that lung moving where there's just air accumulating on the chest wall. So if we look at this a little bit further, we've got skin up here. This is the visceral parietal pleural interface right here, this bright white line. A few rib shadows right there, right here as well. And so as we look at this, you can see right here that sliding back and forth. That is the portion of the lung that is still up versus the stuff down here where there's no sliding, that's where the air is accumulating against the chest wall, between the chest wall and the lung. Okay, so again, lung point, 100% specific for pneumothorax. Okay, so moving on here, we've got, we're going to talk a little bit about A lines and B lines and what they mean. And so this is similar to what we saw in that schema where they were talking about A profiles and B profiles, same thing. So what we've got here on the image is a normal lung. Okay, so we've got some rib shadowing here. We've got skin up here, visceral parietal pleural interface right here, the bright white line. Then as you go down through the air, you get this artifact of these horizontal lines. Okay, so that's normal artifact from an air-filled lung. B lines, which we'll see on the next slide, are representative of fluid in the parenchyma of the lung. So fluid accumulating in the alveolar. There's a number of things that can cause that, and we'll see what the difference is here with the A lines and B lines. Okay, so as I mentioned, pulmonary edema, contusion, and pneumonia, very similar findings. The one thing that they all have in common is B lines. All of these things can cause fluid to accumulate in the lung. They're of different pathophysiology, but they can all cause B lines. Okay, so this is an example of B lines here. So we've got skin up here, chest wall, visceral parietal pleural interface right here, the bright white line. And as you can see, there's no horizontal lines coming down here, but you can see these sort of like rays of light, or some people will call them like rocket tails. Okay, so these are what we're talking about when we say B lines. These are B lines. Okay, these tails coming down. Okay, and so that's artifact created by fluid within the lung itself. So when we talk about pneumonia, can definitely cause B lines, cause fluid accumulation in the lung. Other findings for pneumonia will be bronchograms, consolidations that you can find, and then also some C lines. And we'll talk about a little bit more what C lines are here in a couple of slides. And for pulmonary contusion, we're looking primarily patients that we would expect to have pulmonary contusions, right? So, these aren't your patients that are just dyspneic from no apparent cause. Like, these patients had chest trauma. They didn't just develop a contusion on their own. They had to have some sort of inciting factor. Okay, so, image the patients that you think have contusions, with, I guess, with knowing what you're looking for. So presence of B lines and C line potentially. Typically, the B lines for contusion are going to be focal in nature. So you may be imaging and see normal lung, and then as you move down rib spaces, you may find that you have B lines in one rib space and then normal lung either side of it or just above it. That focal appearance of B lines is fairly indicative of pulmonary contusion, because as you imagine, if somebody gets hit in the chest or struck in the chest, it's a specific area. It's not the whole lung that's going to be contused, it's just that area. Okay, so looking for those focal B lines. So pulmonary edema, again, looking primarily for B lines because this is a fluid accumulation in the lung. It typically occurs bilaterally. It doesn't affect just one lung. And it's typically diffuse in nature. So if you're seeing B lines all the way throughout both lungs in a patient that's dyspneic, that has CHF or some condition similar to that where you would expect them to have pulmonary edema, or it's definitely on your differential, that would be, a very specific finding for pulmonary edema. So a couple more words on pneumonia. It typically starts posteriorly and inferiorly. So this is the one scan where you're going to want to try and start in the posterior aspect. And what you're going to want to do is find the most inferior portion of the lung. So you're going to want to find the diaphragm on the back side of the patient and then work your way superiorly, looking for any sort of focality that you can see. We'll talk a little bit about focal findings with the C lines here on the next slide. But you're going to work, as I mentioned, inferior to superior, and then you're going to also work around laterally. And those are sort of the most high yield areas for finding pneumonia. Okay, so this left-hand image is an infant patient. So you can see these small rib shadows here. Again, visceral parietal pleural interface here, skin up here. And so you can see the pleura kind of comes along nicely here, and then you have this divot with some B lines, okay? Same thing here, so divot, some B lines, as we would expect, fluid in the lung. So this sort of parietal or visceral parietal defect here in the pleura is indicative of a focal finding for pneumonia. The other finding that we did talk about a little bit earlier is the air and fluid bronchograms. And so in this image, what we're looking at is these hyperechoic sort of flecks that we can see. These are air bronchograms, okay? These static hyperechoic sort of dots, okay? The fluid bronchogram is this little speck here that we can see. So it kind of see it moving down into the lung there. And so basically what's going on here is where the pneumonia's sitting in the lung, you've got air bubbles that are squeezing down through the fluid that's accumulated in that pneumonia along the airways of the lung. And that's what you're seeing here is with that little dot that's moving is air bubbles moving in the fluid. Okay, and that's called a fluid bronchogram. These static dots that don't move with breathing, those are air bronchograms. Okay, so we're going to sort of finish up here. We've got a couple of pathology images to look at here. So we'll start here on the left. So what we're seeing here, we've got skin up here, okay, chest wall, couple of rib shadows here, and then we've got the visceral parietal pleural interface here, okay. And so as you can see, this patient, we're scanning multiple rib spaces, okay. So as we start over here, okay, we've got normal, we've got some A lines there, and I'll show you one more time. So these horizontal lines you can see, those are A lines, which are, like we said, are normal. And then as we move up a rib space, we've got, oh, no A lines. We've got those lines coming straight down right there, okay? So those are B lines. Okay, so we've got normal lung, we've got some B lines. So that would be a focal appearance of B lines, which would be indicative of a pulmonary contusion. If we move over to the right-hand side here, okay, we've got, this is a right upper quadrant image. Okay, so we've got liver over here on the right-hand side of the screen. We've got the diaphragm right here, okay, and we have a couple of findings here, okay. So if we look below the liver, we've got vertebral bodies down here below the liver, which is normal, okay. But as we go up here above the diaphragm, we continue to see vertebral bodies above the diaphragm, okay. And so we would call that a positive spine sign, okay. And if you remember, that's because we've got some sort of process going on in the thoracic cavity that is able to conduct ultrasound waves. And if we look further here, we can kind of see this fluid accumulation here. So this is lung that we can see sort of flapping about in the fluid here, okay? So we've got fluid around the lung in the thoracic cavity, which in combination with that and the positive spine sign is highly suspect for pleural effusion. Okay, so just finishing up here, a couple of words on pulmonary embolism. So the current data doesn't really show enough sensitivity with this study to actually rule out PE. And there's some findings with PE that can be really challenging to image. So primarily what you're looking for is the presence of C lines, which was that focality that we looked at with pneumonia. Pulmonary embolism can have a similar sort of appearance. But if you imagine we're imaging a large surface area for a very small finding, and so it can be really challenging to locate that area. And if you didn't find that particular area, you could call something negative that is potentially positive. So it can be a little bit challenging to find what you're looking for. However, there is some specific benefit for different populations. So patients that are too unstable to go to the CT scanner, but you're sort of undifferentiated in what's going on, doing this could give you a little bit better idea of maybe what sort of pathology is going on with that patient. Patients with damaged kidneys that cannot get IV contrast, these are patients that you could still definitely image. Patients that have allergies to contrast, or patients that you can't radiate for whatever reason, pregnant patients, that kind of thing. There is some other etiologies or some other modalities of imaging that you can use in sort of patients that can't get contrast or have an allergy or can't receive any sort of radiation. You can do nuclear medicine studies, which can give you sort of a VQ mismatch, which is indicative of pulmonary embolism, but doesn't show you exactly where the embolism is. And as I mentioned earlier, it's sort of a constellation of findings. You can see some right heart strain on ultrasound. You can see the subpleural defects or the C lines that we talked about, or you can see maybe the presence of a DVT in a patient that's dyspneic. That would be suggestive of, or somebody that's acutely dyspneic with a DVT, that would be indicative of something's broken free and lodged in their lung or something like that. So hopefully you got something out of this lecture. Like I said, we'll have a little bit of time at the beginning of our scanning session for some question and answers in relation to sort of how we do the scan, what we're looking for, that kind of thing. And I'm going to send out a couple of different videos. They're fairly short. One will be primarily on sort of the approach to doing this, like what image should I do first, that kind of thing. And then one will be primarily based around the like lung sliding to do with pneumothorax, because I feel like that's sort of the most challenging concept to sort of wrap your head around for this specific topic. But hopefully we'll get a good amount of time scanning so everyone can feel comfortable with this particular scan. Thanks.